Good afternoon and welcome to Lungitude Foundation's 2021 Lung Transplant Research Presentation. Very, very excited to have everyone for our second virtual research presentation. Unfortunately, out of necessity, we would love to be face-to-face or at least having a hybrid meeting with some virtual and some face-to-face representation today. But unfortunately, out of necessity, we're going virtual, but that does enable a lot more people from around the country to attend as well. So welcome. Today, as we've done previously, we've got a number of different experts and speakers presenting today who have all been instrumental in the great research work that's been supported by many of you on the call today. So we'll be breaking this up into 4 different talks, and it will really focus on past, present and future as it relates to the lung transplant work, the research work that the team have been doing. Associate Professor Bronwyn Levy will be introducing each of the speakers today. We will have a question and answer session after the first 2 speakers, Dr. Lucy Sullivan and Jay Azarani. And then we'll have a very brief break, a 5-minute break for you to grab a coffee or something before we go into the second part of the agenda with Professors Greg Snell and Glenn Westall. And that will also be followed by a Q&A. And then we'll finish up today. So that time will take us a full hour and a half today. And just as a flag to those who have some additional questions that we may not be able to get to through the course of the presentation today, the speakers, the panelists will all be available for an additional 15 minutes after the official ending of this session today. So really welcome questions as we go through. Before I introduce Bronwyn, just as a reminder, there is on your screens, hopefully you'll be familiar, there's either a chat box or a question and answer function. So we really encourage you, as the presentations are progressing today, pop your questions in either of those boxes, preferably the Q&A box, and then we'll make sure that they're addressed as we get to the Q&A section. Before I hand to Bronwyn, I'd really like to thank on behalf of Lungitude, our key supporters, many of whom are represented on the call today, and so in particular the Gillespie Family Foundation, the Giddis family and Mr. Tony Pratt as well. Without their generous support and their passion, a lot of this work obviously wouldn't be possible. We're also very grateful for our other supporters who are on the line today as well, and for those who support the work of Lungitude and the research group today. So without further ado, I'll hand to Bronwyn Levy. So just by way of introduction, Associate Professor Bronwyn Levy, many of you will know as Bron, has been involved in this area of lung transplant research and supporting and working with the team for many, many years. And we're very grateful for the work that she does on a day-to-day basis, but she's also a member of the Lungitude board and represents the group there. So I'm going to hand over to you, Bron, to introduce our fantastic speakers today. Many thanks.
Thanks very much, Catherine. So I'm going to introduce now the first 2 speakers. First up today is Lucy Sullivan, Dr. Lucy Sullivan. Lucy is a well-known researcher from Australia. She is an immunologist and has her research is focused very much on the lung and immunity and the immune system, how that affects the lungs. And that's why she's been very much involved with Lungitude and our research with lung transplant. And she used to work at the Doherty Institute here in Melbourne, but has recently moved to take over and run the lab at Red Cross Lifeblood in Adelaide in the immunology department there. And our second speaker for today is Dr. Jay Azarani, who is a consultant within our team at the Alfred Hospital. Jay was our lung transplant fellow last year, and he has been undertaking some research work with us in the department this year as his first year as a consultant. So I'm going to hand over to Lucy now to present her talk. Thanks very much, Lucy.
So thank you so much, Bron, for the introduction there. And as Bron mentioned, I have been involved with lung transplant research for a long time now, and I've just recently relocated back to my home state in Adelaide. And I'm going to do a bit of a back to front talk here and doing the acknowledgements first. And just to say this research that I'm presenting is really a team effort. And it's been driven largely the lab work in the Doherty Institute, and particularly in partnership with Sander Stankovic, and obviously working very closely with the team at the Alfred Hospital and Red Cross Lifeblood. And I've really got to say a big thanks to the Lungitude Foundation that have funded a large proportion of this research that I'm showing today, and also the lung transplant patients without whom this research just wouldn't have been possible. So by background, transplant rejection is caused by the recipient's immune system. And the recipient's immune system respond to these proteins in the donor that are called human leukocyte antigens, or HLA. And HLA are very different between different people. And so this donor HLA is seen as foreign, much like if you got an infection. And so the recipient's immune system responds to this foreign HLA, and it can cause rejection. And unfortunately, lung transplantation has more rejection than other organ transplants. So the overarching objective of our research was to investigate pre- and post-transplant parameters to improve survival following lung transplantation. So the focuses that I'm going to be talking to you today about some past research we've done is to look at improved donor-recipient HLA matching, to improve diagnosis of rejection, to look at the role for novel immune cells in fighting infections following post-transplant, and also looking at a role for the donor's immune system in the lung transplant recipient following transplantation. So the first piece of information I'm going to talk to you about is improved matching. So as I've mentioned, these HLA proteins are highly variable, but they do have features in common that are called eplets. So just to briefly explain what these are, if we look at these proteins on the whole protein level, they're very different between these different proteins. But you'll notice that they have features in common, and we call these eplets. So we thought that rather than looking at matching on a whole protein level, could it be possible to improve donor-recipient matching using these eplets? So what we noticed is that when we looked at eplet matching, rather than having most of our recipients being mismatched on 4, 5, or 6 whole proteins, we saw a more even distribution of mismatching when we look at eplet mismatching. And what we then looked at is whether we could predict survival based on eplet mismatching. And what we saw is when we looked at this, the donor-recipient combination that had the least eplet mismatching in this blue line had the highest survival, and this is more than 10 years post-transplant. I should say this is work done by Steve Hiho at the Red Cross in Melbourne. So just by way of summary of this small part, so a low eplet mismatching is associated with improved overall survival following lung transplantation. And where this leads us to is the incorporation into eplet matching into a pre-transplant assessment, and where we can determine thresholds for compatibility between donors and recipients. And it can also be used to guide immunosuppression following transplantation based on how matched or mismatched they are in terms of eplet matching. So we're now looking at our research in post-transplant assessment. And the second research program I'm going to touch on is perhaps a better way that we can look at diagnosing rejection following transplantation. So really for many, many years, the diagnosis of rejection is looking down a microscope, and you can see these here, where you can see these dots, and these are recipient immune cells that come into a lung. And this is the way that for many years rejection's been diagnosed. But it's associated with many problems, and it's prone to sampling error, so it depends on where you take this biopsy of the lung. And it's also research has shown that there's poor agreement between independent observers with this method. So we need better tools to diagnose rejection so we can intervene earlier. And a tool that the teams looked at is the diagnosis of rejection by what's called a molecular microscope. So instead of a traditional microscope, it's looking at a piece of tissue, a biopsy, using molecular methods. So what they do is they take a small biopsy and they look at the expression of these different genes following transplantation, with the idea that different types of rejection will come up with different patterns of gene expression. And this is then put into a computer, and the computer identifies this pattern of rejection in order to diagnose and categorize rejection. So what this research has shown is that what's called a high T cell score was associated with rejection following lung transplantation. And what's also come out of this is it looks like this MMDX, or molecular microscope diagnosis, is a safer option for recipients instead of traditional biopsies. And furthermore, we can use this to guide immunosuppression. So I'm just now going to switch tack and talk to you about why immunosuppression is so important. So as I've mentioned, donors and recipients differ in terms of HLA, and we need immunosuppression to stop the recipient's immune system reacting to the donor HLA. But what we need is a really fine balance. So too much immunosuppression, we'll get infection, and too little immunosuppression, and we'll get rejection. So what we really want is this balance where we have the right amount of immunosuppressions that we don't have rejection and we don't have infection. But unfortunately, because of the immunosuppression, transplant recipients often get infections following transplant. And these are often with pathogens that are normally relatively harmless. And one of these is cytomegalovirus, or CMV. So this is a very common virus, and it's 50% of the adult population is infected with this virus in Australia, and this is up to 90% in some other countries. So this virus is of little consequence in healthy people, as your immune system would normally keep it under control. But with the immunosuppression on board, this allows for this virus to replicate and to cause disease following transplantation. So this disease can be very harmful and can even result in death. And besides the disease itself, CMV can result in increased risk of other infections, an increased risk of rejection, and also a higher overall mortality in recipients that have this CMV disease than recipients without. So therefore, controlling this is critical to transplant success. In our research, we really wanted to look at, so immobilising the good guys, if you like, the good immune cells that can control CMV. And over the years, the team has looked at multiple immune cell subsets, including some called cytotoxic T cells, these other guys that have a cool name called natural killer cells, and also a third type of cell that I'm going to be talking to you about today that's called gamma delta T cells. These are some publications here that we've published in these research areas. So these gamma delta T cells are really a bit mysterious. They are 1 to 10% of your immune cells in your blood, but they're really highly enriched in the lung. So we know from studies of healthy people that they are involved in your immune response to infection, but they hadn't been looked at in lung transplantation. So we looked at gamma delta T cells in lung transplant recipients with and without CMV. And in doing so, we actually described a new subset that I'll call these 2C gamma delta T cells. So what we saw was that even prior to transplant, if we're looking here at the amount of these 2C cells, and in recipients, lung transplant recipients without CMV and lung transplant recipients with CMV, even prior to transplant, those who had CMV had a higher proportion of these 2C cells. And if we look post-transplant, we see that during CMV infection, and this is CMV infection in the lung, that these 2C cells really go into the lung during this CMV infection. And we then see them afterwards become more abundant in the blood. And we then did some experiments in the lab where we got some cells and we, in the lab, infected them with the CMV virus itself. And we then, in the lab, also put on our gamma delta T cells that were either these 2C positive or these 2C negative cells. And we looked to see if they were activated by the presence of these CMV infected cells in the lab. And so what we saw was quite striking. If we're looking at how activated they are up here, you can see that these 2C positive cells are far more activated than the 2C negative cells by the presence of these infected CMV cells. Just summarising this, we saw evidence that these 2C gamma delta T cells are important for the control of this virus that really causes a lot of trouble following transplantation. So where we're hoping to drive this is looking at cellular therapy harnessing these cells where we can use them in the clinic. And we're also looking at developing a diagnostic test where we can see if the recipients are already protected from CMV by sort of a high number of these 2C cells. And we were successful in 2020 in getting a patent treaty application for this project. So just the last question, the last program that I want to talk to you about is whether the donor's immune system could actually contribute to the health of the recipient or detrimentally following transplantation. And we, a couple of years ago, we actually described an instance where we show that antibodies that were being produced in multiple recipients that have received an organ from the same donor, they were actually all producing the same antibodies. So we concluded that the antibodies that were being produced in these multiple recipients were actually from the donor itself. So this led to us asking the question, do these donor-derived immune cells actually persist in lung transplant recipients? So I won't go into details of the assay except to say that we actually use the fact that the donor and recipient different in HLA in order to track donor-derived cells following lung transplant. And we looked at correlating these with rejection. So what this shows here, rejection, also known as CLAD, if we looked at the recipients that didn't have rejection in the black versus recipients that did have rejection in the red, those that didn't have rejection had a much higher proportion of these donor-derived immune cells post-transplant that persisted for much longer following transplant than recipients that did have rejection. So in this case, we actually think that donor-derived immune cells are a good thing following lung transplant. So where we're hoping to drive this is that we think that donor-derived cells could possibly be used as a biomarker of protection from rejection. Alternatively, they could be used as future therapy if we really nut down which subsets of immune cells are involved in this. So I guess what I really want to highlight today is that sort of discovery-based, lab-based research really does matter, and we can translate that into real impact in the clinic. We can use this research to monitor recipients for rejection and infection using appropriate biomarkers. We can use it to develop better diagnostics. We can use it to tailor immunosuppression to target specific populations. And likewise, we can also use more specific immunosuppression if we know which cells are involved in rejection. So that's all I have to you today. Thank you so much for listening. I'm happy to answer any questions in the Q&A section.
I think we're handing straight to Jay, who's sharing his screen. Thank you so much, Lucy. And over to you, Jay.
Hopefully everyone can hear me. Lots of familiar faces in the participants list, so it's great to have the opportunity to talk to you all in a non-clinical setting. I'm briefly going to talk about lung function and the utility of it and some techniques that we're looking at making commonplace after lung transplantation and how these are going to help us in the future. So we'll talk a little bit about the purpose of lung function, what we currently do to measure lung function, and this new type of lung function called FOT or FOT. We've got some interim data that we'll show you guys and then briefly talk about the future. The purpose of actually measuring lung function after a transplant, it's pretty obvious. It's an objective marker of your lung health, and to have a look at how the actual life of the organ is going and how the health is in terms of infection and rejection, as Lucy pointed out. It's good to map out a trajectory of your journey after lung transplantation. We don't really have normal values for lung function after lung transplant. It's more of a trend. So each measurement is really measured against the one before. A lot of the problems that happen after lung transplant don't necessarily have symptoms. I don't know, maybe our patients are very resilient and they suffer in silence, but we don't often see any problems unless we actually actively go looking for them with our lung function. And often that's the first sign that something needs to change or something needs to be fixed. Early detection is obviously the key for early management for things like rejection and infection. Once we get to the chronic rejection stage, things obviously get a little bit harder. Currently, we're doing spirometry to measure lung function. We do this very often, and it's a good tool. It's a good technique. We've used it for many years. It's currently the gold standard, and it does detect diseases that don't have symptoms, which is great. We've got some good data out recently, a month ago, showing that the lung function measured at 12 months gives us a lot of information about how the patient's health and life is going 12 months on for a transplant. But it's not perfect. And I don't need to tell everyone, or 99% of the people in the cohort, that lung function measured via spirometry is quite cumbersome. I'm going to try and play this video for the benefit of the people that haven't done this, but it's sold as an easy test, but it's not simple. You have to put your face on a mouthpiece. You start off with normal breathing into a machine that's connected to a wall, and you sort of take small breaths in and out. It looks pretty benign at this stage, but it does get a bit worse. You sort of have to take a breath in and then smash out the biggest breath you can and hope that the numbers are going to be as good as last time because you're being compared to yourself. They're not showing this guy's face here, probably because he's blue, but this technique is difficult. And then you've got to take this big breath in and sort of pretend to have tolerated it well. Everyone says that this is an easy test to do, but really, I've done many. I've had a lot of asthma in my life, and I hated doing these as a child. The other thing to talk about is how good is this piece of technology that we've used for so long? Is there something better? Is there a more high definition test we can use? And is there something we can use in different settings? Obviously, because of the strenuous nature of this test, we can't do it straight after surgery. We can't do it after you've had a cataract. If you've got rib fractures, it causes a problem. It depends on the clothes you wear and the effort you put in on the day. So is there something a little bit more high definition, a little bit more sensitive? A good example of where spirometry, which is this type of lung function, has not given us a lot of information is a study done after the World Trade Center collapsed, where a lot of people who had lung function done before the World Trade Center collapsed and then subsequently got exposed to all the dust, started developing a lot of symptoms of sort of inhalational dust exposure, and their spirometry was normal. So the lung function didn't pick anything up despite these people having sort of a dust injury in their lungs. And someone decided to use a new method of lung function, which I'll talk about, FOT, and saw what the results were amongst these patients, and it actually fit with the symptoms. And this lung function did detect early resistance that standard lung function didn't pick up, and the results were abnormal. This new lung function is called FOT or IOS. IOS is a type of FOT. FOT stands for Forced Oscillatory Technique. Basically, it's a type of lung function that doesn't require any effort, and it uses sound waves that get projected inside the lungs, and then there's a little machine inside that detector which looks at the sound waves being reflected back. Depending on the pressure and the flow changes, we can tell if there's increased resistance within the lungs, and and if there's a problem. iOS, like I mentioned, is a type of FOT where we use multiple different frequencies. And the best part about this is we can try and isolate where the problem is in the lung. Is it in the small airways, large airways, or middle airways? More about that a little bit later. This is what the new lung function FOT machine actually looks like. That's the mouthpiece, and that's the sort of chronograph that we see on the computer. And I know a lot of you have already done this as part of a study we're doing at the Alpha, but here is how it works. It's so simple that even this child can do it without struggling. You end up looking like a little bit of an emoji with your hands on your cheeks, but that's to sort of eliminate the resistance from the cheeks. And basically, the scientist presses a button and you just breathe normally in and out through this mouthpiece and let the machine do all the work. And that's literally it. There's no breathing out. There's no huffing. It doesn't matter what clothes you've worn on the day. It doesn't matter if you've got rib fractures. That's all you need to do. This is a sort of a diagram of what's inside the machine. There's a loudspeaker here that sort of projects sound waves through a bacterial filter, through your mouthpiece. It goes into your lungs, and then the sound waves get reflected back into the machine where it gets picked up by the pneumatic chromatograph, which maps out the waves. And all of this stuff is to sort of clear out the dead space ventilation and calibrate the results. So it means something meaningful. Interestingly, because you don't need to huff and blow out, a lot of editorials have been written about how good this thing is because it's less aerosol generating in times of a pandemic. Basically, because you've got a lot of sound waves going through at different frequencies, we know that the lower frequency goes all the way down to the deep pockets inside the lungs, and the higher frequencies go to the main airways. So basically, we're isolating the site of disease, whether it's a large airway, a small airway sac problem, or a middle airway issue, which is quite interesting. We haven't been able to do that before. There's been a lot of work done in COPD patients using lung function and spirometry. These sort of lines represent different stages of severity. All of these people have abnormal lung function, and the people at the top have worse lung function in terms of their spirometry. These people also had FOT done, and they found the abnormality with COPD patients actually lies within this frequency. So when we use these sound waves, we know that the problem is actually in the small airways. So instead of just saying the lung function is abnormal, it gives us more information as to where the abnormality is. Also, it detects it sooner rather than later. It's been used in asthma as well, especially amongst children. And this study looked at the symptoms of asthma and symptoms of asthma control. And when the symptoms, which is mapped here on the y-axis, got better, the lung function using FOT actually reflected a change as well. No change detected in normal spirometry, but as the symptoms improved, the measurements on FOT improved as well, which means it's giving us more high definition information. Now, how does this translate to lung transplant patients? Obviously, it's a complicated process having a lung transplant, and there can be many different problems at many different sites. The problem can be in the large airway, in the trachea. It can be the site of the join from the new lungs to the old lungs, at the anastomoses. It can be in the box containing the lungs, the chest wall, the ribs, the muscles, in the small airways, in the airway sacs, or even fluid around the lungs. So isolating where the problem is actually quite important, and if so, more important in people with lung transplants than any other sort of disease group. It has been studied, FOT has been studied in lung transplant patients before, and this is a really good sort of graph showing spirometry, so normal lung function tests after people were diagnosed with rejection on their biopsy. There is actually no change in lung function before and after the treatment for acute rejection. This is the point of rejection, and you can just see the lung function here tells us absolutely nothing when it's measured by spirometry. It's up, it's down. But when we look at FOT, you can see that the lung function is getting more and more abnormal as we go up. At this point, the person gets diagnosed with rejection and gets treated for rejection, and then you see that lung function drop off. If we're in a stage where we can't do biopsies on everyone as we would like to, and we just did this lung function, having a look at this trend would actually give us very useful information as to when a biopsy is needed. So again, more sensitive, more high definition, and gave us information that we didn't already have with spirometry. This is a basic look at some of the data we've collected with chronic rejection. So that previous slide was looking at acute rejection. We've had 195 patients across this centre at the Alfred and across interstate centres as well, measuring a type of FOT with people who don't have rejection and people who have different types of rejection. And there are differences. There is inherent changes in the small airways resistance pattern amongst people who have RAS, which is a restrictive allograft syndrome, which is a type of lung transplant rejection. So it does translate. Changes in this new lung function do demonstrate what's happening within the lungs, and more importantly, where the problem is. And here it was found to be in the middle airways. So how does this relate to the future, and what can we do with this moving forward? Obviously, detecting things early is of utmost interest to us. We want to find the problem so we can start fixing it earlier. A study is underway. We're looking at a longitudinal analysis for FOT on everyone who has a lung transplant in a selected group, and chasing them through their journey and finding out what the FOT numbers actually mean and relating them to spirometry. Because it's a less strenuous type of lung function, we can do it earlier in the course of your journey. So we can think about doing it sort of day 7, day 8 post-surgery, and whenever you like. It doesn't matter if you've had any other surgeries in the body or rib fractures. We can still do the test because it's less strenuous. And we need to work on seeing this as an adjunct tool currently. And, you know, maybe in 5-10 years, it's the only tool we need to use to measure lung function. But we obviously need to understand it a bit better before we get there. That was my last slide.
Thank you so much, both Lucy and Jay, for your presentations. There's a couple of questions just actually in the chat I can see there. Someone's asked, would a patient know about having CMV prior to going into the transplant surgery?
The adult lung transplant program doesn't have it, but the paediatric hospitals might well have it because it has been used in children quite a lot. Jay?
So it's being incorporated into standard of care and probably will be in the next few years at our children's hospital as well, but largely experimental. And yes, it is available at the Alfred Hospital.
Question there, Jay, about ambiguous results in single lung transplant for using FOT, because you've got the native lung there.
Very, very good question. And we will only be able to answer it once we study it in a cohort of patients with a single lung transplant and actually map out how it tells us about the new versus the native lung. But it's the same as spirometry, because you are affected by the native lung even with normal lung function. So it's a problem that we've had for a long time, and it's a problem that we'll continue to face.
Okay. There's another question about FOT as an assessment tool in a place like Ballarat. You know, some of the smaller labs at other hospitals, but I don't think that's available as yet. Is that correct? And another couple of questions. If recipients don't show any symptoms and then they're not picked up, could it cause more damage? I don't know who wants to answer that. Jay, Greg?
I guess the point is to pick it up as soon as possible so it doesn't cause more damage. And early detection is key, exactly like Lucy was saying as well. She's developing molecular techniques to pick these things up earlier on biopsies, and we're working on developing techniques in lung function to pick these things up earlier so they don't become too much of a problem later. So acute detection and management is the key.
Okay, thanks. So there's a couple of questions in the chat. Lucy, I think I'll throw this one to you. Is Eplet mismatching testing being done on lung transplant recipients?
So yes, this is something that we can look at and record. The incorporating it into an allocation system is a work in progress and something that we're looking towards. But also it's not just the pre-assessment and the compatibility and the picking the right donor, but it's also important to look at post-transplant as a sort of stratification of risk of rejection, if you like.
And so one of the other patients, I think, has asked, is it possible to find out our level of Eplet matching and donor-derived immune cells?
You mean personally?
Personal, yeah, each patient, from a patient point of view.
I think we'll have to defer to our ethics protocol as to whether it's okay to release individual information or not. But certainly from the researcher's perspective, all of the information that comes to us is coded. So we don't actually personally, as the researcher end, know who is who. And it also just pertaining to the donor-derived immune cells, depends on how far out post-transplant that the patient is. So we know even in the recipients where the persistence lasts really by about sort of 12 months, the donor-derived immune cells, we really can't detect them following 12 months post-transplant.
We are using the Eplet scores to help with determining the immunosuppression after transplant. So if someone gets, say, troubles with their kidneys, or someone gets lots of skin cancers, we might use that to decide whether we have to run with the standard recipe of immunosuppression, or whether we could run with a little less or a little more. And I think that's the way of the future, being able to use this type of information to individualize the treatments.
I also just add a comment is that, you know, what is a common theme with all these presentations is that they make sense to us as good ideas, and what we're doing is evaluating them in a research setting to confirm a hunch, if you like, that they are the way of the future. And if it turns out that they are, the idea being is that they do become standard clinical practice at some point in the future, and hopefully not too far away in the future.
There's a couple of other questions about FOT. I'm just going to throw. So the current FOT trials underway, have we got any insights from that? I think, Jay, what you presented was a little bit of data that we have so far, but we've still got a little way to go. Is that correct from that? A couple of questions about when will FOT replace current testing, do we think? So
it'll take many years. I think we're still sort of understanding the bare bones of it, and this is where all the data and the science of it becomes important. Like Glenn said, it's a hunch. We need to prove the hunch.
And there's a question about one of the patients has a home spirometer, and his results are consistent around 100%. At what point would I be considered for FOT?
I think, as Jay suggested, we'll go through a period where we're using both of them side by side, and in doing so, we'll be able to compare the two tests. But we're envisaging a future where, in fact, we'll only be doing FOT, but there will be this kind of transition period.
Bron, I might just jump in there because I think we're just about at time for this session. I think there may be one or two further questions which we haven't been able to get to, but we can probably come to maybe at the end. So I think that fantastic first two talks, really exciting, all of these incremental improvements which make such a big difference to patients at the end of the day. So big thanks. We're going to have a 5-minute break now. Just before we go to the break, like we did last time, we're very, very curious to understand who we've got online, where you're attending from. So that helps us to understand and prepare for these events in the future. So if you wouldn't mind, just as you're heading out to maybe grab yourself a coffee or stretch your legs, if you wouldn't mind indicating where you're watching from and the other two questions, and then we'll share those results as we return back. So big thanks to our first few speakers, and we'll see you now in 3 or 4 minutes. Thank you very much.